Vậy xin mời các bạn theo dõi bài giảng của thầy. Sau đó thì chúng ta sẽ có cái phần Q&A. Thì các bạn có thể giơ tay để phát biểu, hoặc các bạn có thể là inbox câu hỏi để chúng tôi sẽ thay các bạn để đọc trả lời. Vâng, Professor Zisman, please your start.
Okay, thank you. So this is about the past, present, and future of testosterone deficiency in diabetes and obesity. And we have different types of hypergonadism that can be caused by a testicular damage, by a pituitary adenoma, and also that can be functional, such as in obesity. And when we look at the aging process of men, we can see that testosterone levels are generally stable. So these are male beings starting from boys 3 years old up to men who are 90. And you can see when they go into puberty, testosterone levels increase up to maybe 14 or 15 nanomole per liter. And then they remain stable, not as in women where you have a decline around the age of 50, but in men, testosterone levels are persistently high in the normal range on average. But as you can also see, there are some men around the age of 50 who become hypergonadal. And this is very interesting. Why does it happen to them? Or do they have secondary or primary hypergonadism or something else? And if you look at these curves, you can see that they were distributed according to the body mass index. And men who have a normal body mass index below 25 seem to have a low prevalence of hypergonadism. Maybe there is a little bit of age trend to a higher prevalence. But if you also look at the blue line, which is the BMI between 25 and 30, you can still see there is not much of an evidence or prevalence. But when you look at those men who have a BMI about 30, you can see that independent from age, you have a very high prevalence of hypergonadism. So that basically means it's not sort of so much, a little bit, a matter of age, but it is much more a matter of body mass index, a matter of obesity than of age, if you find hypergonadal men. Why is that so? It is because you have the visceral fat tissue that produces substances that can interfere with the production of testosterone. First of all, there is leptin. Leptin comes from the visceral fat, which is here, which can be seen on the MRI image in orange. And that interferes with kisspeptin released from the areas superior to the hypothalamic region. And of course, then GnRH release is affected, and also the release of LH and FSH from the pituitary gland, so that the testes cannot produce testosterone anymore. In addition to that, leptin can also interfere with Leydig cell function. That means directly testosterone production is suppressed. At the same time, you have pro-inflammatory cytokines. They do principally the same that leptin does. They interfere with the central regulatory mechanism, but they also interfere with Leydig cell function. And the third mechanism is, of course, the aromatase, which is situated within fat tissue and transforms a lot of testosterone to estradiol. And estradiol also gives a feedback to the central mechanisms that there is enough of steroids, and LH and FSH should not be produced anymore. So basically, we have three substances here: leptin, cytokines, estradiol, that all work together in obese men to suppress the hypothalamic pituitary function and partly also the Leydig cell function. So we have a type of mixed hypogonadism. Of course, there is no real disease behind it, but there's a lot of fat tissue. So we call it functional hypogonadism. And you might think that, just losing weight would improve the problem. And this is correct. If men have diet and exercise, you can see that if they lose their body weight, maybe 10 to 20%, they gain T levels around maybe 3 to 4, maybe even 5 nanomole per liter. This is possible if they are able to lose their weight in their hypogonadal state. If these men are really obese, and I know that in Vietnam, this is not very often the case, but this very much so in the Western countries, in the United States, but also in Germany, then bariatric surgery might help. So losing body weight in such a case for maybe 30 to 40% will lead to a marked increase of testosterone levels. So that's a good sign. But of course, that is not only the way that we should go, because many men are not able to lose weight in such a way. And regarding this functional hypogonadism, the European Academy of Andrology has created guidelines, recommendations for the diagnostics of functional hypogonadism. And we know that functional hypogonadism should be looked for, especially when we find men who have the disorders as follows: obesity, type 2 diabetes, and the metabolic syndrome. So it is recommended that these men change their lifestyle, and that would include physical exercise, weight reduction in these overweight and obese men, since this may increase T concentrations. But we will also come to what the EAA says concerning testosterone substitution, because that really works. This is a smaller study in which men who were obese and had functional hypogonadism and were also newly diagnosed with type 2 diabetes received either testosterone gel or just diet. So those receiving testosterone gels also had a diet, but in addition to that, they received testosterone replacement. The others were just controls only on diet. And after 9 months, you can see that the HbA1c in those receiving diet did not really improve. But we could show that those men who received testosterone gel in addition decreased their HbA1c from about 7.7 down to 6.6. And this is a marked decrease, which can also be achieved by normal anti-diabetic drugs, but here we just replaced a natural hormone that was deficient anyway. So this is something that is really good, and we will look at new data, whether this can be confirmed in larger groups as well. First, we can have a look at the T trials. The T trials comprised about 800 older men. They were all older than 65. Their T levels were lower than 9.5 nanomole per liter. They also received testosterone gel, but here versus a placebo gel in a prospective and randomized placebo-controlled and double-blind manner for 1 year. And metabolic function was one of the aspects that was investigated during these trials. We have seen from the trials that, of course, other things were improved, such as sexual functions, physical functions, mood and energy increased, depressive symptoms were attenuated, metabolic parameters, as we will see, were improved, mitigation of anemia was seen, bone density was increased, and there was a very good safety profile compared to placebo. There was no increase in prostate carcinomas or incidence of cardiovascular events. So based on that, the EAA guideline issued recommendation number 10. That means we recommend testosterone replacement therapy in hypogonadal men who have a functional hypogonadism and sexual symptoms to improve that mainly libido, erectile function, and sexual satisfaction. And this is regarded as a very high level of evidence. Let's take a look on what happens in the T trials on glucose metabolism. On the left side, you can see insulin secretion. On the right side, insulin resistance. And in orange are those men who received testosterone gel. And you can clearly see insulin secretion and insulin resistance decreased, while it slightly increased even over these 12 months in those men who were just receiving a placebo. But this is not a real confirming study. This is just a hint because these men were not all diabetic. To this end, there is a new study that has just been concluded. And this is the T4DM study, testosterone for diabetes mellitus. And this trial lasted for 2 years. It took place in Australia in 6 centers, and men were enrolled who had low testosterone levels and were obese. They had functional hypogonadism. And you will see who was included here. You can see these were men who were 50 to 74 years old. They had low testosterone levels. Here, the threshold was even 14 nanomole per liter. And they were at risk for type 2 diabetes or had newly diagnosed type 2 diabetes. And you can see the criteria below according to plasma glucose concentrations. So there was one group of around 500, more than 500 men receiving a lifestyle program. That means physical activity and change of diet plus testosterone therapy. And the placebo group was also more than 500 men. They had the same lifestyle program, but they only received placebo injections, not the real testosterone injections. All this lasted for 2 years and they were constantly surveyed. And what you can see from the lifestyle and baseline parameters, these men were around 59 to 60 years old. They had a markedly increased waist circumference, a BMI around 35, which is really high. But you can see these groups were comparable. And what happened? This is the main result. How many men had type 2 diabetes after 2 years? In those men receiving testosterone plus lifestyle changes, you can see there were 12%. But in those group, in the 400 who remained then after 2 years were gone, there were some dropouts as in any study. You can see that those receiving placebo plus change in lifestyle, there were more than 20% having a type 2 diabetes. And this is a highly significant difference. The relative risk to have type 2 diabetes was reduced by more than 40% when testosterone was added to the lifestyle program. And you can also see this from a mean change from a baseline in 2-hour glucose after glucose load, a standardized glucose tolerance test of 75 gram oral glucose solution. And those men receiving testosterone had a marked decrease of 1.7 millimole per liter versus less than 1. millimole per liter in those receiving placebo. And also this difference was highly significant. Let's take a look at those men who had type 2 diabetes after the study had been concluded. And those men receiving testosterone who were at high risk for type 2 diabetes, this is only focusing on those who did not have type 2 diabetes in the beginning, but how many men progressed to type 2 diabetes. So that also means, does this testosterone treatment provide a prevention to go into the diabetic state from a pre-diabetic state? And you can see that some men in testosterone treatment, marked here in yellow, proceeded from a pre-diabetic to a diabetic state, but these were only 7.6%, while there were almost 15% in those men receiving lifestyle and placebo injections. And the lifestyle change program was very rigorous. They had to work hard. They had to do physical activity at least 3 times per week and follow a strict diet, but that didn't really help. So the difference is markedly significant, and the relative risk to go into type 2 diabetes from a pre-diabetic state is reduced by 50% when testosterone therapy is added. There was also a reversal from type 2 diabetes into a non-diabetic state, which is very rare. It can be seen and it has been described, and there are criteria for men who go back from type 2 diabetes into a non-type 2 diabetic state. That means type 2 diabetes which was long regarded as something that cannot be cured, was actually cured here. And you can see that the difference between the groups is marked. 13% more of those men receiving testosterone therapy reverted their diabetic state into a normal state than in those receiving placebo. And if you look at some other parameters, you can see that the probability to normalize blood glucose and fasting glucose is improved. Waist circumference, fat mass, and abdominal mass is going down, while total muscle mass, arm muscle mass, and muscle strength increased. This is, of course, something that should be observed over a longer time. And here we have data from men who were being treated with testosterone and having type 2 diabetes in functional hypergonadism over more than 10 years. And in those men who were treated, this is the black curve, HbA1c decreased markedly, while it slightly increased in those marked in red. So that means those men being on control, they had anti-diabetic treatment, but that didn't really help them. So the HbA1c increased over time. And you might say, yeah, these are studies and we do not really know if there's a bias or something. This is a meta-analysis. There were many smaller trials, and basically this did not even include the big T trial and the T40M study. And you can see that those men who were randomized to be treated in functional hypergonadism with testosterone treatment or being under control, they changed their body composition. They lost fat mass, they gained lean mass, and you can see that fasting glycemia and insulin resistance went down when men received testosterone. This is a real good result. And basically, this is also reflected by mortality. These are men with type 2 diabetes, almost 600 people are being followed up for 6 years. And you can see that their mortality is going down when they are being treated with testosterone. These are the men marked in green. In red, you can see those who are diabetic but have normal testosterone and do not require additional testosterone treatment. And you can see in green those who were treated, and their mortality rates are the same. But there are also men who have type 2 diabetes and hypergonadism and were not treated. And these are marked in blue, and you can see their mortality is twice as high. And you can see it develop on the right side over time. So this is a clear indication that testosterone treatment in hypogonadal men with type 2 diabetes has a preventive function. And this is, of course, as we see from the famous UKPDS trials, which are now almost 23 years old, but they are very big, a very big trial. You can see that a reduction of HbA1c by 1% leads to a reduction in myocardial infarction, a risk for stroke is reduced, and the risk for peripheral artery disease is markedly decreased. And of course, this has flown into the development of guidelines also from diabetes specialists. This is the American Association of Clinical Endocrinologists, and they have published guidelines as well. And you can see that they say that men who have an increased waist circumference who are obese should be assessed for hypergonadism and tested for their T levels. This is very important that these people say that it is necessary to check obese people for hypergonadism. And they also say that all men with type 2 diabetes, which is basically the same, but not really completely, they should also be evaluated to exclude a testosterone deficiency. And men who are hypogonadal and obese and are not seeking fertility. Seeking fertility is something else, then you cannot treat with testosterone. But those who are not seeking fertility should be considered for T therapy, in addition to lifestyle intervention. Definitely, you cannot just give testosterone gel and wait for the patients to improve while they are sitting. So they also have to change and go into physical activity and change their diet. This is quite an agreement with what the EAA, the European Academy of Andrology, says. They say we suggest the initiation of testosterone replacement therapy for functional hypergonadism when it is really diagnosed. And this is because we go into the metabolic syndrome state and we go into hypergonadism, and both reinforce each other by lifestyle, which is not adapted to the human body, lack of physical activity, overnutrition, smoking, and stress. And we know that this leads to endothelial dysfunction and type 2 diabetes. And finally, we see the cardiovascular events and myocardial infarctions and other cardiovascular problems. And yes, of course, we can interrupt all these problems by changing the lifestyle, by substituting hypergonadism, by substituting testosterone, and also do other interventions. If there's high blood pressure, we must treat. If there are lipids are high, we must treat. If we cannot really control glucose, we must treat with respective drugs. So the take-home messages are that men with functional hypergonadism, obesity, and type 2 diabetes have a large array of benefits from testosterone therapy. That has now been proven not only by the two trials, by smaller trials involving testosterone gel, but also by the big T40M study. And so there are several societies, including the European Academy of Andrology, recommending a simultaneous testosterone treatment of underlying disease and, of course, hypogonadism. Thank you very much.
Thank you, Professor Zisman, for a nice presentation today. I would like to listen to the questions from the audience, please. Các bạn đã nghe bài trình bày rất là hay của thầy Zisman rồi. Thế thì bây giờ các bạn sẽ đến cái phần thảo luận. Chúng ta sẽ có khoảng độ 10 phút để thảo luận Q&A cho phần này. Thế thì các bạn có những câu hỏi gì thì xin các bạn giơ tay để các bạn tương tác trực tiếp, sẽ có người phiên dịch cho các bạn. Và người đầu tiên tôi xin mời bác sĩ Hồ Nhật Quang. Vâng, xin mời bác sĩ Hồ Nhật Quang ạ.
Dạ em chào anh Bắc ạ.
Chào bạn.
Alo. Dạ em có câu hỏi cho giáo sư là trong thực tế lâm sàng có một số trường hợp bệnh nhân nam trẻ trong vòng khoảng độ từ 30 độ lại hoặc hơn một chút, chưa kết hôn hoặc đã kết hôn nhưng mà đang mong con và bị suy giảm testosterone. Thì trong những trường hợp như vậy á, thì xin hỏi giáo sư là cái khuyến cáo điều trị cho những trường hợp này là như thế nào ạ? Cái việc sử dụng testosterone ngoại sinh như mình biết là nó sẽ gây ảnh hưởng đến cái sự suy giảm sinh tinh ở người đàn ông và có thể ảnh hưởng đến cái sự thụ thai sau này. Cảm ơn anh ạ.
Vâng, cảm ơn bác sĩ Nhật Quang.
I'm trying to see the translation, but I see that when I go into English, I cannot see it. Yeah.
Could you sharing your experience
Yes,
about the patient
treat with testosterone,
hypogonadism with male infertility,
and then not only decrease testosterone production by the testes, but also spermatogenesis. So there's a contraindication to give testosterone when the man wants to father a child. Then we have to do something else. Gonadotropin therapy is something that really works, giving HCG to mimic LH function. So HCG binds to the LH receptor, and then testosterone can be produced in the testes. We can also, in addition, because that sometimes is affected, give recombinant FSH. And then most of the men should be restored. There's also the possibility to go to an off-label oral treatment. That means blocking the estrogen signal. And that can be done by tamoxifen, 20 milligram per day, by a SERM, selective estrogen receptor modulator, or by clomiphene, same dose, 20 milligram per day. Or you could inhibit estradiol production by an aromatase inhibitor, such as anastrozole or letrozole, 1 milligram per day. Definitely, these men will have a benefit. But of course, then you have to look at bone density. So they have the benefit of an oral drug, which is off-label. They have to pay themselves. But in most cases, it will work, but you have to check bone density. So the gold standard, but also the more expensive way would be to give gonadotropins. Yeah, to tell you, the translation seems to be inactive. I see that translation is inactive. I do not know why. I can click on English, but I cannot. I do not have any result.
Thank you, Professor.
There's also a translation now coming. Yeah. So there's one question that says, I'm focusing on the correlation between type 2 diabetes and male hypergonadism when it comes to diagnosis. Could we have any strategy to clarify if type 2 diabetes occurs in advance, or is it the result from male hypergonadism? And in your research for type 2 diabetes, along with testosterone replacement, were participants treated with type 2 diabetes drugs as normality? Well, in my research, in the research that we did with Rostov University, we just treated with diet and exercise in both groups and not anti-diabetic drugs. And this was also the case in the T trials, and it was also the case in the T40M study. So this is much clearer then. In the 12-year study that comes from Germany as well, there were anti-diabetic drugs because it lasted so long, but you could see that those people could be taken off their medication if the therapy lasted longer. And when it comes to diagnosis, what is first? What is the hen and what is the egg? Basically, it can be both. Testosterone deficiency can be the first thing to be there, and then insulin resistance develops. But also type 2 diabetes can be first, and the whole insulin resistance situation, the high insulin levels can cause hypergonadism. So in principle, both conditions can cause each other, and they are reinforcing each other. So I would not exclude that the causality is two ways. And so there's a question: is it conflicted with the right of patients? Since type 2 diabetes leads to a lot of complication. Yeah, I don't really understand this question. I think that these patients are really monitored very well. And we look at the complications along with centers for the care of type 2 diabetes, such as kidney and eye function and blood pressure and blood vessel function.
Thank you, Professor, for nice answering. Tôi xin comment thêm một ít về như thế này. Thứ nhất, đối với cái trường hợp mà bệnh nhân mà vô sinh mà có suy sinh dục, như lúc câu trước của bạn Nhật Quang có hỏi ấy, thế thì chúng ta cần phải xác định xem là cái suy sinh dục này là suy sinh dục nguyên phát hay thứ phát. Về mặt nguyên tắc thì khi mà chúng ta bổ sung testosterone vào là ngoại sinh, nó sẽ ức chế quá trình sinh tinh. Tuy nhiên thì nếu mà chúng ta có thể sử dụng trong một thời gian rất là ngắn thì nó cũng không ảnh hưởng gì nhiều đến cái quá trình sinh tinh cũng như là số lượng tinh trùng, bởi vì chúng ta sử dụng dài thì mới được. Bởi cái điều này đã được minh chứng trong một cái nghiên cứu của một cái tác giả năm 2016 về cái việc mà điều trị sử dụng testosterone dạng gel bôi sau 3 tháng thì ảnh hưởng như thế nào đối với lại số lượng chất lượng tinh trùng. Thì cái sự khác biệt giữa trước và sau điều trị hoàn toàn là không có ý nghĩa thống kê. Sự khác biệt về các thông số nội tiết tố, đặc biệt là FSH thì cũng không có nghĩa thống kê. Tuy nhiên những cái nghiên cứu dài hạn trong cái việc mà điều trị testosterone ấy, để điều trị suy sinh dục thì rõ ràng là thấy nó có một cái cơ chế ức chế ngược. Vì vậy mà đứng trước một cái bệnh nhân mà các bạn điều trị cho bệnh nhân suy sinh dục mà có vô sinh, các bạn sẽ phải hết sức cân nhắc xem là có nên quyết định điều trị bổ sung testosterone từ ngoài vào hay không. Cái phần thứ hai, khi mà các bạn phải quyết định đấy là suy sinh dục thứ phát thì các bạn sử dụng những cái thuốc khác mà có tác dụng kích thích cho tinh hoàn sản xuất tinh trùng và kích thích cho tinh hoàn sản xuất quá trình sinh tinh. Ví dụ như các bạn có thể sử dụng clomiphene, tamoxifen, hoặc là các bạn cao cấp hơn các bạn có thể sử dụng gonadotropin, hoặc là các bạn có thể sử dụng cái nhóm thuốc mà ức chế aromata mà như giáo sư đã đề cập đến. Thì đấy là liên quan đến cái vấn đề mà vô sinh và suy sinh dục, chúng ta cần phải lưu ý như vậy. Cái vấn đề thứ hai là liên quan giữa cái sự suy giảm testosterone với lại tiểu đường. Đây là một mối quan hệ mà con gà và quả trứng.
So,
Cho đến bây giờ thì người ta chưa đưa ra
is
bằng
Dr.
chứng rằng
Bach
là
asking
suy giảm
anything?
testosterone thì gây ra tình trạng tiểu đường, hay là tiểu đường gây ra suy giảm tình trạng testosterone. Tuy nhiên người ta chỉ thấy rằng như thế này, ở trên một bệnh nhân mà bị tiểu đường, nếu có suy giảm testosterone mà chúng ta kết hợp điều trị suy giảm testosterone bằng testosterone thay thế thì nó sẽ làm tăng cái hiệu quả điều trị tiểu đường lên, kiểm soát đường huyết tốt hơn, sớm đưa được đường huyết về cái ngưỡng như mong muốn dưới 6. Thì đấy là cái evidence mà chúng ta đã có. Và ngược lại, trên một bệnh nhân mà suy sinh dục mà có tiểu đường, nếu chúng ta điều trị và kiểm soát tốt được tiểu đường đi thì nó sẽ giúp góp phần cải thiện được cái nồng độ testosterone lên, trở về cái mức bình thường. Và cái này cũng đã là có evidence và được chứng minh trong cái kết quả cái nghiên cứu của thầy Zisman lúc trước cũng có trình bày với chúng ta. Vâng, xin mời các bạn có những câu hỏi tiếp theo gì nào không ạ? Bạn nào có câu hỏi nữa không ạ? Nếu mà chúng ta không còn câu hỏi nữa.
Xin chào anh bác.
Nhật Minh đúng không?
Dạ vâng ạ, dạ em là Nhật Minh.
Ok, rồi chào. Rồi xin. Và bây giờ là một cái câu hỏi cuối cùng. Xin bác sĩ Minh.
Hello, Dr. Michael. Thank you so much for your beautiful slides. I just have one question. Usually, in the young men with the over exercise can lead to low level of T. So, do you have any experience in treatment of this kind of patient like a gamer? Professor Michael, can you hear me?
I cannot. No, I cannot hear the question. No.
Okay, it's my question.
You would have to tell me.
Can you hear me now? Hình như có vấn đề gì anh bác ơi?
Chắc là đã có cái vấn đề về mạng đấy.
Dạ vâng.
Thầy.
Can you hear me right now? Okay.
Yeah, because I have here the translate function and it says it does not work.
Is my question is.
Minh ơi, thầy Minh ơi, thầy Minh đặt câu hỏi bằng tiếng Việt đi, để cho cái bộ phận dịch trong kia dịch ra, bởi vì là cái kênh nó không truyền được.
Dạ ok anh. Dạ.
But I can only hear you. I can only hear your voice.
Câu hỏi của em là trong trường hợp một số nghiên cứu người ta chỉ ra rằng cái việc mà mình tham gia cái hoạt động thể lực quá mức, những over exercise chẳng hạn, như những cái gamer chẳng hạn, thì nó có thể dẫn đến cái nồng độ testosterone thấp. Thì cái kinh nghiệm mà trong cái việc mà mình tiếp cận những cái bệnh nhân này nó như thế nào, mong muốn kinh nghiệm từ của giáo sư Michael. Em cảm ơn ạ.
Cảm ơn bác sĩ Minh. Bộ phận dịch truyền tải thông tin cho thầy đi.
So if there's someone who does a lot of physical activity and is overtraining, is that correct?
Yes.
Yeah, that would be something that really is a problem in some men that we also see here in Germany, that overtraining leads to hypergonadism. And definitely these patients should not receive testosterone treatment, but they should change their way they do sports, because they obviously do several hours of sports and suppress their levels by overactivity and overtraining. So definitely these men should not be the first ones to receive testosterone therapy, because then basically they should reduce training amount and then be monitored and see if they recover. There's also a question that was written.
Trong lúc chờ đợi cái câu trả lời, câu hỏi tiếp theo của các bạn, thì tôi rất là đồng ý với quan điểm của thầy Zisman, bởi vì đối với những cái vận động viên chuyên nghiệp ấy, nó thường dẫn đến cái tình trạng mà suy giảm testosterone. Cái này nó là suy giảm chức năng Do cái việc
Why is there a case where the second
exercise cho
tease
nên
is
là nó làm suy
successful
giảm
even
cái
though
nguồn nguyên liệu
both the
cung cấp để
first tease and the second
tạo ra testosterone, vì vậy nó
testosterone
làm cho nồng độ
levels are
testosterone suy
high?
giảm. Thì vì vậy chúng ta
Why
chỉ
is
cần yêu
the
cầu bệnh
mechanism of
nhân thay đổi lại cái
spermatogenesis
chế độ luyện tập,
affected?
giảm bớt lại
Please
cái liệu trình
explain
cân nặng, liệu
about
trình tập luyện của họ đi thì sẽ cải thiện được tình trạng testosterone.
phrases FSH resetting and certainly cells resting. Of course you have stem cells. When you have spermatogonial stem cells and nothing else happening in spermatogenesis, FSH is definitely required for these cells to go into meiosis and then further mitosis to become elongated spermatids and finally sperm. And this might take quite a while. So if the first tease was not successful, definitely the spermatogenesis had not come to a stage where this was correct and finalized. We can see this also in men who have congenital hypergonadotropic hypergonadism or Kalman syndrome. It might take up to 4 years that sperm appear. So definitely, yes, you can be too early with the first teasing. It's difficult to determine the time point, but I think it should take at least half a year before you can find sperm. And you can also wait for them to appear in the ejaculate.
Vâng, cảm ơn tất cả các bạn đã có đặt câu hỏi cho thầy Zisman. Bây giờ cũng hết thời gian rồi, chúng ta để dành cho thầy chuyển sang vào cái section thứ hai.
Go into
Professor
the next
Zisman.
presentation, you just tell me.
Yeah, the next slide, please.
Okay. I will go into, yeah, it says,
các bạn đã hỏi xong rồi, đề nghị các bạn bỏ tay xuống nhé.
It does
Các
not
bạn bỏ tay
allow
xuống.
me anymore to share. Now I'm allowed. Okay. Can you see that presentation now, hypergonadism and sexual dysfunction?
Yes, please.
So this is a presentation about hypergonadism and sexual dysfunction in patients who have erectile problems, and I also will show you a case study. Yes, something might start nicely, but then end up with frustration, because male sexual dysfunction is also a problem of the couple. And if you look at the prevalence of any type of sexual dysfunction in a global study of sexual attitude and behaviors, you can see that this affects a lot of men, from 13 to almost 30%. Even in Southeast Asia, it is very prevalent. So this should also be something that can be seen in Vietnam. And the types of sexual dysfunction best known and of course most prevalent are erectile dysfunction, premature ejaculation, loss of libido, and erectile dysfunction is definitely known to almost everyone. And loss of libido and erectile dysfunction are closely related to each other and of course to testosterone, as we will see. Then because symptoms and decreasing testosterone levels are related. So when T levels drop, we see that there is a loss of libido already below levels of 50 nanomole per liter. It's not all in all men, but the probability increases, such as loss of vigor. Erectile dysfunction is also something that is likely to occur, but later when T levels drop. You can see in between there are stages where men have a higher risk for obesity, depression, type 2 diabetes, things like this. So loss of libido comes first, then erectile dysfunction follows as T levels drop. We can see that, of course, the probability for loss of libido is higher when T levels are below 8, but it becomes significant when levels are lower than 15. Above that are also cases of loss of libido. For example, if the couple does not go along well with each other and there's no hormonal problem at all, there also can be a loss of libido. Definitely, this is also a psychological issue, and that has to be seen in different parts from T levels. But when you look at the EAA guideline, you can see that, of course, you should have low T levels for the diagnosis of hypergonadism, can be total T or free T, and symptoms. And you have the symptoms listed here and in marked in red. Now, as we are talking about sexual functions, loss of libido and erectile dysfunction. We have seen this problem before. T levels are persistent over age, but with advancing age, there are some men who develop hypergonadism. And we have seen that this is related to obesity in most cases when men are older. This is not related to primary or secondary hypergonadism in older men, because primary and secondary hypergonadism are things that happen early in life usually. So men with testosterone deficiency present in general practice often when they are not being diagnosed with testosterone deficiency or hypergonadism. They present with obesity, type 2 diabetes, hypertension, dyslipidemia. But when we have this, we have a risk for testosterone deficiency ranging from 40 to more than 50%. So according to the guidelines that I just cited in the last lecture, men who present with these clinical problems should be checked for T levels. So these are silent killers. These are men who have type 2 diabetes, they have obesity, arterial hypertension, dyslipidemia. And this is closely related, definitely. When you go back and you look at these problems, you know that these are cardiovascular risk factors. And cardiovascular risk factors mean that these things affect blood vessel function. So before big vessels around the heart and the brain and the legs are affected, we see microvascular lesions. Oxygen supply to the corpora cavernosa in the chest and the penis are reduced. Transforming growth factor beta is reduced. So we have more collagen, less smooth muscles, and that actually leads to a change of architecture within the penis. There's more collagen tissue and less smooth muscle in the blood vessels, and this definitely means erectile function is going down. We know that erectile dysfunction is something that is not really completely and only related to testosterone levels. This is something that increases with age anyway, because blood vessels are deteriorating. And some studies even say that you can just take the age and say this age is equal to the prevalence of erectile dysfunction. In this study here, you can see it's a little bit less. But why is it so that the erectile dysfunction is earlier than other cardiovascular problems. It's because of the size of the artery. So when a plaque develops in a penile artery, it occludes maybe half of the blood vessel much earlier than a coronary artery or the carotid artery or femoral artery. So there might be plaques in every vessel, but it only becomes clinically significant in the penis, while it is not clinically significant in the other vessels. Could be there. So an erectile dysfunction is a warning signal that in other blood vessels there is something developing. And so erectile dysfunction is definitely not nice to have, but it is good in a way that it is a warning signal that we should check these men for maybe they have other problems. And if we look at this, men who have erectile dysfunction, do they develop type 2 diabetes? Do they develop cardiovascular problems? Do they develop hypertension? And this was done in a group of more than 1,100 men aged 40 to 70. And those men who had erectile dysfunction were twice as likely to develop within 10 years such problems as listed here. So erectile dysfunction can be seen, on the other hand, in those men who have a clinical coronary artery disease, so very often, and in those who have peripheral or cerebral artery dysfunction, erectile dysfunction is present in almost everybody. You know that PDE5 inhibitors such as sildenafil or tadalafil or vardenafil can treat erectile dysfunction only symptomatically. They do not really cure the underlying problem, but it works. And this is what men would expect from these drugs. And we will see what they are connected to testosterone later. But when men are looking at their PDE5 inhibitor, what do they expect from it? They want no side effects, but fast effects, a good erection, a long action. They don't want to pay a lot of money. They want to take it often. They want to split the tablets, and they should work with alcohol. So these are the expectancies of men for these drugs. But for these drugs to work, we will learn we need testosterone. Yes, definitely you can use it for other causes as well, but definitely it's more for a sexual function. And this study is very famous. It shows that the PDE5 inhibitor tadalafil can only work if testosterone levels are normal. If you look quite to the right, T levels below 8, you can see that placebo plus PDE5 inhibitor, you have almost no effect in the IIEF score, which reflects erectile function. But when those men who have testosterone therapy and then have T-gel in addition to tadalafil in this study, and they have T levels below 8 nanomole per liter from the beginning, you can see there's a tremendous effect, and also in those men who have T levels below 10. When they are above that, when they are eugonadal, the effect might still be there, but it's not significant. So you see, Viagra does not work when men are hypergonadal. They need testosterone. Viagra needs the eugonadal environment to be able to work. And there are non-responders for PDE5 inhibitors, and definitely the strongest comorbidity for a non-responder is hypergonadism. There can also be others, such as diabetes, LUTs and BPH, arterial hypertension, dyslipidemia, but Hypergonadism is definitely the strongest comorbidity when PDE5 inhibitors cannot work. Definitely, this is also be something that can be cured easily by testosterone replacement therapy. Let's look at someone who has just this problem. He is 48. He is overweight, BMI 33. He is lacking libido and also has erectile dysfunction. We can see that his total testosterone and his free testosterone are below the lower limit just given here, while his LH is normal. So that means basically this man probably has a functional hypergonadism. You can see that his IEF score and N-aging male score are pathologic. IAEF should be above 26. And AMS score should be below 26, but or 27. But so both show the complaints. This man has an elevated waist circumference. He has normal hemoglobin, but his blood pressure is way too high. His HbA1c is still in quite a normal range, a little bit elevated, but not too much. It's too low to say he has type 2 diabetes, but his fasting glucose is high. So that's definitely something. And his fasting triglycerides are high. HDL cholesterol is too low, but we find no pathological things in thyroid examination and ultrasonography of the testes and the prostate and the thyroid. What we see is something in the blood vessels. This is just a normal control man. And you can see that intima media thickness is, it should be below 1 millimeter. And here it is 0.7. This is a normal finding. But this is the patient. And you can see that he has, compared to this control, where the intima media thickness in the carotid artery was 0.7, he has 1.98 elevated on the right side. On the left, there's even a plaque of almost 4 millimeter thickness. So he definitely has a problem. And when we look at his femoral artery, it is almost blocked by 50%. So his diagnoses are lack of libido, functional hypergonadism, arterial hypertension, overweight. I guess from the fasting glucose, a beginning type 2 diabetes. He smokes, he has erectile dysfunction, he has dyslipidemia, a metabolic syndrome, and definitely also atherosclerosis. Then we started him on testosterone therapy. And this is, he had the criteria fulfilled for functional hypergonadism. So he was started on 2 hubs of T-gel from the T-pump, which is almost correspondent to 50 milligrams from the sachet. So we did blood sampling 4 hours after application. And you can see T levels are fine. LH is now going down. This is quite normal. That external testosterone application suppresses gonadotropin release. You know that this, we have just discussed this. This should not be the case in those men who want to father a child, but this one did not. And we also know that hemoglobin can increase, as does hematocrit. He now feels better. His IEF score is increased markedly. His aging male symptom score has decreased. So both are going back to normal. But according to all these findings that we had here in ultrasonography of the arteries, he was sent to a cardiologist, and then they did a close examination of the coronary arteries, and he definitely had a disease and received 3 stents because he was in risk of myocardial infarction. Definitely, the erectile dysfunction saved him from getting a myocardial infarction, which is good. So the take-home message is that sexual dysfunction in men is a warning signal. Erectile dysfunction means endothelial dysfunction. It is a marker for cardiovascular diseases, type 2 diabetes. We also have something that we did not really talk about because of lack of time. We have premature ejaculation. That can be a marker of lack of serotonin, and that would be a risk marker for depression. And we have loss of libido, which is also a sign of sexual dysfunction that points towards testosterone deficiency, and that is a risk marker for hypogonadism. And hypogonadism can increase depression, and it can increase cardiovascular problems, and it can, as we have learned, the insulin resistance and foster type 2 diabetes. So all these things are connected. Thank you very much.
Cảm ơn
I
thầy
see there are
vì
some,
cái bài giảng rất là hay cho chúng ta cái
but
thông
they
điệp,
are all
mặc
in
dù là cái thông điệp
Vietnamese.
cũ
I
nhưng mà không
cannot
phải không thiếu phần không kém phần thời sự,
You will
bởi vì
translate,
testosterone
I
cương
am
dương
sure.
vẫn là một cái dấu hiệu sớm của báo hiệu các cái bệnh lý về tim mạch cũng như là trầm cảm. Bây giờ tôi xin chuyển sang phần Q&A. Vậy xin lắng nghe những câu hỏi từ quý vị tham gia học ngày hôm nay ạ. Vâng, mời các bạn ạ. Những bạn nào có những câu hỏi thì xin các bạn giơ tay ạ. Hoặc là các bạn có thể gửi câu hỏi vào hộp chat. Vâng, xin mời bạn bác sĩ gì? Rồi. Ok, mời bạn. Bạn tên là gì ạ?
Alo.
Dr. Nguyễn Hiền.
Dạ. Alo.
Rồi mời bạn Hiền, bạn đặt câu hỏi đi ạ.
Dạ, thưa thầy, thằng em nói ạ.
Nghe được rồi bạn ơi.
Dạ. Dạ, cảm ơn thầy. Dạ, thưa thầy, xin các thầy cho em hỏi là khi mà có một bệnh nhân mình gặp về họ có biểu hiện của một cái rối loạn cương dương thì mình sẽ đánh giá tất cả những cái xét nghiệm mà về cả những cái bệnh lý mà như thầy giáo sư vừa nêu đó, hay là mình chỉ đánh giá theo cấp bậc các cái xét nghiệm? Tại ví dụ như những bệnh nhân họ tới với một bệnh Việt Nam mình, như thầy biết là cái béo phì thì nó không được phổ biến lắm, nhưng mà ở nước ngoài như bệnh lý ở những phương Tây như thầy thì nó khá là nhiều. Nếu em thắc mắc về những bệnh nhân như thế thì mình tới để có biểu hiện của loạn cương dương, ngoài những xét nghiệm cơ bản như mình biết đó, thì mình làm hết từ những cái xét nghiệm để đánh giá chức năng về mạch máu, tim mạch và tới đường. Dạ, hay là mình chỉ đánh giá theo từng thứ tự để được hướng dẫn tốt nhất? Em xin cảm ơn các thầy ạ.
Yes, definitely. We should check his blood pressure, maybe even a 24 blood pressure check. And we should check his fasting lipids. And these are parameters that can also be checked, like high resolution C-reactive protein to see if there's some type of inflammation. It should also check for a lipoprotein type A. This is something maybe the endocrinologist will not do, but the cardiologist or the normal physician. So we have to form a network of physicians here. And it is always good if the andrologist has a close connection to others who are specialized in artery disease, for example, or cardiology. So, or might even be in neurology if we see that cerebral arteries or the carotid arteries are affected. So yes, definitely there are other lab values to be tested. And I think that it is good to involve other specialists here as well.
Và các bạn còn bạn nào có câu hỏi nữa không ạ? Các bạn có câu hỏi nào không ạ? Tôi cũng hoàn toàn đồng ý với cái phương án trả lời của thầy Zisman, bởi vì như thế này, Nam học sức khỏe nam giới là một đa ngành, là một cái chuyên ngành mà nó đa ngành, bởi nó liên quan đến tất cả các chuyên ngành khác nhau. Ví dụ tim mạch, nội tiết, chuyển hóa. Thế thì đứng trước một người bệnh mà đến với chúng ta vì có cái triệu chứng mà rối loạn hoạt động tình dục, đặc biệt là rối loạn cương dương, mà lại có yếu tố mà béo phì, thì chúng ta nên tầm soát lại những cái yếu tố nguy cơ về tim mạch cũng như là yếu tố về rối loạn chuyển hóa. Thì yếu tố nguy cơ về tim mạch thì các bạn có thể chuyển cho bệnh nhân đến khám chuyên khoa tim mạch. Tuy nhiên về những rối loạn chuyển hóa thì các bạn có thể tự tầm soát được bằng thông qua những cái xét nghiệm về thông số mỡ máu, cũng như là các bạn đo huyết áp để tầm soát những cái đơn giản trước. Khi mà có vấn đề gì thì các bạn sẽ có thể hội chẩn chuyên khoa. Vâng, xin mời cái câu hỏi thứ hai ạ. Câu hỏi thứ hai, xin mời bác sĩ Vũ Lê Tân.
Dạ, em chào anh Bắc và em chào thầy. Em là bác sĩ Lê Vũ Tân ạ. Em có một cái câu hỏi
Lê Vũ Tân ạ.
Dạ, em có một câu hỏi là những cái trường hợp ca lâm sàng như vậy chúng ta sẽ dùng testosterone là đường đến khi nào, và cái ngưỡng khuyến cáo nồng độ testosterone để chúng ta nhắm đến khi điều trị những trường hợp này là bao nhiêu, và bên giáo sư có dùng testosterone đường uống hay không, và cái cách mà để ông hạn chế cái tác dụng phụ của testosterone đường uống là như thế nào?
If we can stop the therapy for a while and see whether he has recovered, but that only makes sense if he has lost a significant amount of waist circumference. Maybe if the waist circumference has gone down to less than 94 centimeters, then it might make sense that we can stop it, the T therapy, see whether he is normal again, not before. How long? Yeah, we would treat for at least 2 years, then stop it in some men whom we think they could have recovered.
The last questions, please. Xin mời bác sĩ Vũ Lê Tân. Vũ Lê Tân ạ. Một câu hỏi cuối cùng. Bác sĩ Vũ Lê Tân có được không ạ?
We will see then.
Dạ, anh nghe không anh Bắc ơi?
Bác sĩ Vũ Lê Tân đặt câu hỏi đi.
Dạ.
Bạn đặt bằng tiếng Việt đi, bởi vì thầy sẽ không nghe được cái kênh.
Em đặt bằng tiếng Việt,
Anh
em
của các bạn.
bằng tiếng Việt đó anh. Dạ. Em hỏi thầy là bên thầy có điều trị testosterone bằng đường uống hay không, và cái cách để mình hạn chế cái tác dụng phụ của testosterone đường uống là như thế nào, và cái trường hợp này cái trường hợp giống như cái ca lâm sàng này đó anh, thì cái ngưỡng mà cái nồng độ testosterone mà chúng ta nhắm đó trong cái quá trình điều trị chúng ta là đưa lên cỡ bao nhiêu là vừa? Dạ.
Yeah, we have the oral preparation testosterone undecanoate, which is named Andreol. And of course, you have to give it along with a fatty meal, 2 capsules 3 times per day. And then you might have T levels which are not really reliably within the normal range, but it can be the case in those men who really want an oral drug, and it is not absolutely bad to use it, although it is not as good in terms of kinetics as the gel or intramuscular injections. You might have heard that in the United States, there's another oral testosterone which is available. It is called Jatenzo, and it's also testosterone undecanoate, but with a different galenic preparation. And the kinetics are much better, but we do not have it in Germany, and I guess you also do not have it in Vietnam yet. But it will come, I guess, from during the next years, and then we have a good oral preparation. Okay.
2 more questions, please. Xin mời bác sĩ Nguyễn Nhật Minh.
Dạ vâng ạ. Dạ em xin đặt câu hỏi bằng tiếng Việt ạ. Em có một câu hỏi cho thầy Zisman.
Bác sĩ Nguyễn Nhật Minh.
Dạ vâng ạ. Anh nghe em rõ không ạ? Dạ anh nghe em rõ không ạ? Dạ anh nghe em rõ không ạ?
Alo, bác sĩ Minh đặt câu hỏi đi ạ.
Dạ vâng ạ. Thì em có một câu hỏi cho
bác sĩ Minh ơi.
Dạ vâng, anh có nghe em không ạ? Anh có nghe em không ạ?
Ok, xin mời bác sĩ Hồ Sĩ Nhật Quang, bác sĩ Quang ạ.
Dạ.
Bác sĩ Quang.
Em có câu hỏi.
Bác sĩ Quang đặt câu hỏi đi ạ.
Dạ, anh nghe không ạ? Alo. Alo. Xin câu hỏi giáo sư là cái thời gian hồi phục trục dưới đồi tinh nhân tinh hoàng cũng như là cái thời gian khôi phục sự sinh tinh sau khi ngừng cái liệu pháp testosterone là bao lâu ạ?
Mất loa ngoài này à? Ôi, chiều này có loa được đâu?
Yeah, this is a very good question. And this really depends on the type of testosterone that you give. If you give a transdermal gel, then the recovery is fast. It takes less than a month for gonadotropins to come back. If you give intramuscular injections, I've just looked at the data from the old trials for male contraception, where we have normal men who received testosterone undecanoate. It can take up to 4 or 6 months for gonadotropins to fully recover. But for the gel, it's less, maybe 1 month.
Vâng, bác sĩ Nhật Minh đã chuẩn bị câu hỏi xong chưa ạ?
Dạ rồi ạ, em có câu hỏi là cho giáo sư là trong những cái trường hợp Trong những cái trường hợp mà mình chữa bệnh lý chuyển hóa hoặc là đái tháo đường chẳng hạn, là rối loạn chức năng tế bào đồi nội mô nó dẫn tới tàn rối loạn cương, thì trong những trường hợp này giáo sư có sử dụng là testosterone như là cái đơn liệu pháp. Vậy trong những cái trường hợp có trường hợp cái để mình sử dụng luôn cả cái BDE5 inhibitor trong cái trường hợp mà mình muốn cải thiện cái chức năng cương cho bệnh nhân, đi kèm với cải thiện cái libido cho bệnh nhân. Đó là câu hỏi của em.
Yeah, this is a very good question because it affects the conflict between guidelines and reality. Some guidelines say you should use the PD5 inhibitor first. Some guidelines say you can only use testosterone first, but in daily clinics, you will have an impatient man who wants his sexual function to be restored. And what I usually do is I talk to him and that the possibilities are there. And most of the patients will agree that they receive testosterone therapy plus a PDE5 inhibitor because they want to have a fast effect. And you can also assume that if they are obese and they have type 2 diabetes, they do not only have the hypergonadism, but they also have blood vessel damage that cannot be cured. So they need a PD5 inhibitor anyway. And they need a PD5 inhibitor along with testosterone because the PD5 inhibitor alone will not work. So in most cases, yes, I give both.
Cho em một câu hỏi nhỏ nữa được không ạ? Nhắm thôi ạ.
So yeah, I will try to.
Giáo sư nghĩ như thế nào về việc sử dụng testosterone qua đường mũi so với đường da hoặc là đường uống ạ? Và giáo sư có kinh nghiệm gì trong cái việc mà mình sử dụng testosterone qua đường mũi không? Nasal.
The nasal form Natesto I have heard about, but we do not have it here in Germany yet. I have seen kinetic studies. Men should apply it 2 times per day, and as I have heard from the United States, it works quite well as long as men do not have any kind of infection or viral disease that affects the nose. But when they are healthy in that regard, the nasal spray is something that can be considered, but I cannot use it because I do not have it in Germany. I only hear from friends in the United States. Maybe do you have it in Vietnam?
No, it's not available in Vietnam.
No, yeah, but I think this is something to come, just as the oral. It's all good. I'm here.
Thank
to
you,
talk
Professor.
with you.
Professor,
That's
for the
all
next
fine.
section, please.
Okay, I will do that. I hope you can see this diagnosis and treatment of Klinefelter syndrome, the EAA guideline. EAA guideline was published this year. I wrote this together with other experts on the syndrome. And basically, we know that the Klinefelter syndrome is something really complicated because it involves genetics and developmental issues in children, in puberty and adolescence. It has a clinical picture in adults. It involves hypergonadism, and fertility, psychological health, bone health, metabolism, cardiovascular risk, and other things. So it's really something that is more complicated than you might think. It was described by Harry Klinefelter, after whom it is named, in 1942, last century. He did not know about chromosomes because they were not detected yet, but he could show that these men had gynecomastia, they had hypergonadism, and had increased FSH. That hormone was known by then. Patricia Jacobs in 1959, after the chromosomes had been detected, found that these men have 2 X chromosomes. And that's really was a market news as well. How does it happen? It can come from the father's side or from the mother's side. The father's side is here marked in blue and the mother's side in red or orange. And it is always an error during meiosis. It can be in meiosis 1 or 2 in the woman, where you have an egg cell with 2 X chromosomes, or it can be during last steps of meiosis in the man, where you finally have a sperm that carries an X and a Y. Finally, it results in all the same, a zygote with an additional X chromosome, 47XXY, which is the typical Klinefelter karyotype. These are boys with the Klinefelter syndrome. They were detected because of amniocentesis in the mother. And you might think that they could have some kind of genotype, but not always the case. The adults present about 0.2% of the male population, which does not sound so much, but it is every 500th man. So that's the most frequent chromosome disorder that we can find in males. These men have small testes, usually a tall stature, long legs, and gynecomastia. They have most often a hypergonadotropic hypergonadism. Most of them are infertile. They have metabolic problems, altered bone physiology, cognitive problems, but a very heterogeneous phenotype. It's not always the case in every man. But we can see here pictures from Klinefelter patients, and you can see that they are feminized, they have less muscles, they have gynecomastia, they have abdominal fat. A background check shows that these men have an increased morbidity and mortality from several causes. When you look at morbidity, you can see that it's not only related to testosterone, but also to other things, such as infection, cancer, psychiatric problems, neurological, circulatory, pulmonary problems. So many things listed here. You can see where the hazard ratio is increased, that these men might become sick. And the next thing would be mortality. And this is also increased, especially from infections, neurological problems, circulatory problems, but also suicide. So we have psychological issues here as well. And we know, yes, this is the karyotype that we would find. And we would always think about the Klinefelter syndrome if we have elevated gonadotropins, we have a hypergonadotropic condition, And then we might have low testosterone, endocrine testicular damage is there, we have hypergonadism. And also the exocrine testicular damage is there. We have infertility. That is also how it might be detected with azoospermia and high levels of LH and FSH. And this is, of course, due to a disturbed gene activation pattern. You might think that one of the X chromosomes is inactivated, but there are pseudo-autosomal regions on the X chromosomes. That means in some cases, some genes on both X chromosomes are active. For example, the Klinefelter syndrome can also occur in cats. Cats have normally 38 chromosomes, but the Klinefelter tomcat might or will have 39, also have XXY. And in cats, fur color is inherited on the X chromosome. And if you have a tomcat looking like this, orange and black, two colors, but a tomcat, usually only a female cat has two colors, then this points towards a status of a Klinefelter syndrome. These tomcats are infertile, but they are just a very good example to show that the X chromosomes are both active, at least in cats. Let's see what happens in men. So these is a study that we did in more than 150 Klinefelter patients. And you can see now here are genes which are upregulated in Klinefelter syndrome versus normal male controls with a karyotype 46XY. And red means upregulated. And you can see that many genes are upregulated on the X chromosome. There are also some from the Y chromosome, from pseudo-autosomal regions. And also autosomes are involved. Not many, but some. You can see that here. Let's focus on the sex chromosomes. Especially here, you can see genes from the X and the Y chromosome. And these, which I have marked here with a blue, show you genes which are present on the X and on the Y. So we have 2 copies from the X and 1 copy from the Y. That means 3 active copies in Klinefelter syndrome, which is, that might cause a gene overdosage effect. The KDM6A is not present on the Y. It's only active in 2 copies, but it should be only active in 1 copy, because men have only usually 1 X chromosome, not 2. But in the Klinefelters, it is 2. And KDM6A is responsible for heart development. This is important because we have also a cardiac phenotype, and we will see that. In Klinefelter patients, we find that waist circumference, independently from age, is increased. So less than 40 years, older than 40 years, it's higher than in the male controls. You can see that. Klinefelters are marked in red, and normal male controls are marked in blue. And thus, insulin resistance is increased as well. And if we look into the PAR genes and the pseudo-autosomal region genes are located on the X chromosome, there are some of them which are marked here, in which the expression is directly related to levels of waist circumference and insulin resistance. You can show the copies related to that, and you can see that the higher the expression of this gene is, the higher the insulin resistance is in the Klinefelters. So the guideline recommends something. They recommend karyotype analysis to detect the syndrome in men who have a non-obstructive azoospermia or severe oligozoospermia. And we also recommend to look in men who have primary hypergonadism. That means low levels of testosterone and elevated gonadotropins combined with small testicular volume, and small would mean less than 5 milliliter per testis. So yeah, we do not have only men, we also have children, and it's difficult to find this in children, but in some cases it might be detected. For example, upon birth, there is cryptorchidism. And in children in pre-puberty, there can be speech and learning difficulties. They can become obvious due to behavioral, social, and psychological problems. Then you might think about this and treat them accordingly, not with testosterone, of course, but some psychological treatment so that they can go into puberty with the best situation they can achieve. But of course, during adolescence, we have more problems. Puberty starts, but testicular growth stops. They have small testes. They have hypergonadotropic hypergonadism or compensated hypergonadism, still have behavioral problems, and of course, fertility issues might emerge. So this is the summary for the therapeutical approaches from childhood to adolescence, and definitely we would have to talk with them about cryptorchidism, evaluate cognitive problems, monitor speech development, support if necessary, evaluate growth, see if the body proportions are fine. We should talk to the patients and the parents about fertility. And of course, as they tend to have bone problems, support them during childhood with vitamin D and also during adolescence. We might treat with testosterone, but we should know that if we give testosterone, we could suppress spermatogenesis. So it might be necessary to treat a Klinefelter boy who is not going well into puberty first with gonadotropins, not to suppress his remaining potential for fertility, because we might find sperm in testicular samples. And then we have the adults. Then we have the adults, and yeah, the adults have a complete picture of someone is talking. So these adults can be found with small firm testes, but usually they come with azoospermia or hypergonadism, signs of hypergonadism, which can be gynecomastia, osteoporosis, obesity, type 2 diabetes, psychosexual or social problems. The risk of neoplasia is increased in Klinefelter syndrome, also is the risk for autoimmune problems. We know in between that they have, or meanwhile, we know that they have ophthalmologic eye problems, retinal dysfunction, impaired day and night vision. They can have dental problems. They can have cardiorhythmic alterations, a reduced QTc time, and they have a higher thrombosis risk. So in adults, we know that we should have them controlled at least annually for malignancies. We should assess their whole status, as they can have so many diseases, and check their hormonal profile and start testosterone therapy if required. That means if hypergonadism is there. We need thrombosis prophylaxis prior to long flights and other risks. We should do a 12-lead ECG because we know that they have cardiac problems. We should check bones in these men and also look at vitamin D. This is basically a lot that you can do and should do in Klinefelter syndrome. This is how likely it is that you can find sperm in testicular biopsies. Overall, the chance is not zero. It is about 50% in some men. In those men who still have low LH and still have normal testosterone. If testosterone is higher than around 7.5, 8 nanomole per liter, LH is still lower than 18, the chance is higher than 50. But if we find that men have a low testosterone and very high LH, the chance goes down to less than 10% to find sperm in a testicular biopsy. And the chance that with these sperm, which can be used for ICSI, for intracytoplasmatic sperm injection, the artificial reproductive technique, is quite high. So we have some Klinefelter, some children from Klinefelter patients, and overall worldwide, these are more than 500 now. And you might think, what is the karyotype of these children? And it is normal. So the Klinefelter fathers have children with a normal karyotype. That means that these sperm have corrected for I'm just giving a lecture. So they have corrected their spermatogenesis. And you can see that partially maintained spermatogenesis in a 19-year-old patient with Klinefelter syndrome. This is a patient with round spermatids. And you have elongated spermatids, you have Pachytene spermatocytes, and you can see that this is an island and within the testes, which is still functional. If you do not work on bone density in Klinefelter patients, you might find something like this: osteoporosis in someone who is just 29 years old. So this is something that has to be checked. This patient has Klinefelter syndrome, and he has osteoporosis already at the age of 29. But you can do something for them. This is someone who is 74. He has been treated with testosterone for 14 years. And you can see that his bone density is normal, even higher than normal. So you can still preserve bone density in these men. And this is now something about the ECG, the cardiac rhythmic function that I have talked about. QTC time is reduced in Klinefelter patients, and especially in those who have their additional X from the father. We do not know why this is the case, but we know that this is the case in Klinefelter syndrome. They have a shorter QTC time, and this is independent of testosterone substitution. And a shorter QTC time might mean that they are likely to have a risk for sudden cardiac arrest due to ventral fibrillation. Actually, in Denmark, where they did a similar study, one patient died when this just was checked. He died in the hospital because he had a ventricular fibrillation. What we also found in our Klinefelter patients, that they have eye problems. They have a small foveal avascular zone. They have a decreased retinal thickness, a cornea with decreased peripheral artery disease, and the perimetry shows that they need brighter stimuli to show a reaction. That means their night vision is reduced. So in conclusion, the pathological conditions in the patients with Klinefelter syndrome are most likely a combined endocrine, genetic, and epigenetic problem. We need, of course, further research because this is really complicated, more complicated than most of us might have thought 20 years ago. It is still vastly underdiagnosed. Maybe 70% of all Klinefelter patients are not being diagnosed. And still, there is an increment of general knowledge on this, and multidisciplinary networks are working, and this is also mandatory. And so I just presented you the first guideline to take a step further towards this goal. Thank you very much.
Thank you, Professor, for the nice presentations. Bây giờ chúng ta sẽ có 15 phút để chúng ta nghe question and answer. Về tôi muốn lắng nghe ý kiến, câu hỏi từ phía các bạn ạ. Bạn nào có câu hỏi xin các bạn đưa tay. Xin mời bác sĩ Nguyễn Nhật Minh. Bác sĩ Nguyễn Nhật Minh nghe được chưa ạ?
Dạ em nghe rồi ạ. Dạ
Okay,
em xin đặt câu hỏi. Dạ. Thì xin ý kiến của giáo sư trong những cái trường hợp mà bệnh nhân có agiospermia trên Klinefelter thì mình có những cái kinh nghiệm gì để gia tăng cái tỷ lệ thành công khi mình thực hiện microtesting trên những bệnh nhân này không? Và cái kinh nghiệm của giáo sư như thế nào đối với việc sử dụng hormone stimulation trước khi mà mình thực hiện microtesting những cái bệnh nhân mà agiospermia trên Klinefelter? Em xin hết.
Cảm ơn bác sĩ Minh.
It is, yes, we do sometimes, because we saw that the testicular values of testosterone production should be there, and serum testosterone must be above 7 to 8 nanomole per liter to have a good chance for finding sperm. We do not really know if a treatment is helpful, but we hope so. And of course, you cannot give testosterone because that would suppress gonadotropins. We give ACG to these men in a low dose to slightly increase their testosterone production, and hopefully also increase the testicular environment so that testicular testosterone can bind to Sertoli cells, and thus increase the potential to foster remnant spermatogenesis. I think we did not really evaluate this, but I think that this is worthwhile.
Thank you, Professor. Các bạn còn câu hỏi nào nữa không ạ? Xin mời bác sĩ Vũ Lê Tân.
Dạ, em xin hỏi giáo sư là kinh nghiệm để mà giáo sư phát hiện ra những cái trường hợp Klinefelter từ cái tuổi mà trẻ hoặc là cái vị thành niên. Tại vì đa phần những cái trường hợp Klinefelter ở chúng ta đó đến khám vì vấn đề vô sinh hoặc là suy sinh dục và đa phần là đều qua khỏi tuổi dậy thì rồi. Thì tỷ lệ mà chúng ta điều trị để thành cái tỷ lệ mà chúng ta điều trị thành công để mà chúng ta có thể có tinh trùng thì rất là thấp. Cái câu hỏi thứ hai là khi mà cái người Klinefelter mà chúng ta làm micro-TC mà thu hoạch được cái tinh trùng đó.
I think it's worthwhile to know the diagnosis as early as possible, because the fertility issue is something that is really important. And I think we have the highest chances to preserve the fertility by testicular sperm extraction in younger years, when the Klinefelter patients are maybe 16 to 20. And so the chance is higher to find sperm than, for example, in an adult Klinefelter who might be 37 and come up with azoospermia and a wife, and then we do not find any sperm anymore, and maybe they have been treated with testosterone before even, so that would not be good. No, actually, we must rely on, there's no program right now. There's no general screening, which I really regret in Germany. We need to rely on general practitioners. We need to rely on pediatricians, that they find something and see it. Actually, it would be quite easy to have a juvenile examination of the testes, maybe at the age of 14 or 15. And if testicular size is then very small, the Klinefelter syndrome should be checked for. But this is not something that is done on a regular basis in Germany, which I really regret.
Thank you, Professor. Các bạn còn câu hỏi gì nữa không? Các bạn còn câu hỏi gì nữa không ạ? Bác sĩ Vũ Lê Tân có muốn chia sẻ thêm gì nữa không?
Dạ anh Bắc ơi, em còn một cái.
Bác sĩ Tân ơi. Và xin mời bác sĩ Đinh Hữu Việt. Bác sĩ Đinh Hữu Việt ạ.
Dạ, em chào thầy bác cùng giáo sư cùng các anh chị ạ. Cho em hỏi giáo sư cùng với lại các thầy bên đại học y là đối với những bệnh nhân Klinefelter này, suy dục mà có azo, thì có cái phác đồ kích thích sinh tinh nào mà nó hiệu quả nhất để cho mình chuẩn bị cho việc mổ micro-TC làm IVF ạ? Em xin cảm ơn.
Vâng, cảm ơn bác sĩ Việt. Thì câu hỏi cũng rất là hay. Câu hỏi này thì chắc cũng đại trùng với câu hỏi của bác sĩ Minh. Thế thì về phía thầy
Yes, as I mentioned,
thầy chia sẻ kinh nghiệm rồi.
We want to increase the probability to find sperm, and it would be experimental to give HCG in case serum testosterone is low. That's the only experimental drug that we have at this time point.
Vâng, chúng tôi cũng hoàn toàn đồng ý với Professor Zisman, bởi vì thế này, cái việc mà làm điều trị để tăng cái khả năng tìm thấy tinh trùng ở những bệnh nhân Klinefelter ấy, bây giờ nó vẫn bằng chứng thì chưa có, kinh nghiệm nữa chưa có nhiều. Hầu hết tất cả các trung tâm chỉ có kinh nghiệm 1 hoặc 2 ca, một vài ca thôi, báo cáo rất là ít. Cho nên là cái này chúng ta thiếu cả bằng chứng lẫn kinh nghiệm. Vì vậy mà đòi hỏi nó tùy thuộc vào thực tế lâm sàng ở mỗi một cái đơn vị. Nếu các bạn có kinh nghiệm gì thì xin các bạn chia sẻ thêm về những cái này. Tại Đại học Y Hà Nội thì chúng tôi cũng không điều trị cái gì trước khi mà micro-TC cả. Tuy nhiên bệnh nhân nào có thì họ sẽ có, mà không thì sẽ không, chứ chúng tôi cũng không có cái chủ trương mà điều trị trước. Xin mời bác sĩ Lưu ạ.
At least we have 140 people here, which is a lot.
Cho em hỏi một câu hỏi được không ạ?
Mời bác sĩ Lưu ạ.
Alo.
Hello.
Cho em hỏi một câu hỏi được không ạ? Trong cái trường hợp Klinefelter ấy thì là vâng, thì trong những cái trường hợp mà dùng HCG mà testosterone nó vẫn thấp, nó không lên được ấy, thì lúc đấy mà bệnh nhân mà muốn có đang mong muốn có con và điều trị chuẩn bị trước micro TC hoặc là TC, thì khi mà cái testosterone không lên được, khi dùng cái HCG rồi thì liệu có cái điều trị gì hơn, hoặc là nó có tiên lượng gì trong cái vấn đề này, tìm được tiêm chủng không ạ? Xin cảm ơn ạ.
Bác sĩ Lưu ơi, câu hỏi của bác sĩ Lưu chưa rõ.
Yeah, if we usually give ACG 1,500 units 2 times per week. We might increase this up to 5,000 units 3 times per week, and in most cases we then see an effect. But if we cannot see an effect and testosterone still stays low, maybe let's say around 3 nanomole per liter, then we do not have any chance to increase it. And we might do the TZ without increasing testosterone levels, just in hope to be have the patient among these 10% we cannot do something. But we do not have any other treatment.
Vâng, em cảm ơn ạ.
Xin mời câu hỏi của bác sĩ Hồ Nhật Quang. Và cảm ơn bác sĩ Hồ Nhật Quang.
Dạ, cho em hỏi giáo sư một câu là cái liệu pháp điều trị testosterone ở những bệnh nhân Klinefelter thì cho những người trưởng thành á, thì mình duy trì đến bao lâu ạ? Xin cảm ơn ạ.
Before we do the TZ, Yes, I think just to give normal testosterone treatment to someone who is testosterone deficient, that I think the Klinefelter patient need a lifelong therapy. You can see this in the one patient that I showed, for example, with the bone density was 74 years old. He required this to maintain his bone density and his well-being. So there's no reason to stop it at one time point.
Cho em hỏi để thêm thầy câu nữa được không ạ? Trong những trường hợp mà bệnh nhân còn trẻ, bệnh nhân Klinefelter ấy, thì cái điều trị HCG cho bệnh nhân mà phải tiêm ấy, thì nó sẽ rất là bệnh nhân trẻ con thì rất là đau và khó chịu ấy. Thì mình có thể là sử dụng các cái loại thuốc để bảo tồn cái sinh sản, đường uống hoặc là các cái thuốc khác thay thế không dùng tiêm được không ạ? Vâng, em xin cảm ơn.
For example, you think about maybe an aromatase inhibitor, or yeah, but I think that would be something that increases LH levels, but we know that the levels are already very high in the Klinefelter patients, and I have never seen that tamoxifen or anastrozole can further increase LH and FSH in the Klinefelter patients because they have primary hypogonadism. The only chance to increase their T levels is to give them ACG, which has a stronger action on the Leydig cell receptors for LH, because it can bind stronger than LH to the LH receptor, and then we might increase T levels. But so ACG is the only chance, from my point of view, that we have.
Vâng, còn các bạn còn câu hỏi gì không? Chúng ta còn một cái câu hỏi nữa. Các bạn còn đặt câu hỏi gì nữa không ạ? Để giao lưu với thầy Zisman. Có lẽ rằng cái topic mà Klinefelter rất là hay đúng không ạ? Vâng. Hôm nay năm nay ban tổ chức quyết định đưa cái topic này vào bởi vì là nó là cái vấn đề mà các bạn gặp phải rất là nhiều trên lâm sàng, và cái thứ hai là nó vẫn còn đang trong cái giai đoạn mà bằng chứng chưa rõ ràng, chủ yếu dựa vào kinh nghiệm mà kinh nghiệm chưa có, cho nên là sẽ có rất là nhiều thứ mà các bạn cần phải trao đổi. Vậy thì chúng tôi đang muốn lắng nghe thêm những ý kiến của các bác sĩ khác, xem là các bạn có những kinh nghiệm gì thì chia sẻ, hoặc là những câu hỏi gì cần trao đổi không ạ? Nếu không thì lại tận một năm sau chúng ta mới được gặp lại giáo sư Zisman đấy ạ.
Cho em hỏi tiếp một câu nữa là liệu có nên sử dụng FSH phối hợp với cả HCG để trước khi điều trị, trước khi làm micro TC không ạ? Nếu mà phối hợp thì liệu phối hợp thêm FSH thì liệu cái cơ hội thành công có cao hơn không, và có khuyến cáo dùng FSH không ạ? Vâng, xin cảm ơn.
Yeah. Usually the Klinefelter patients have very high FSH. So they do not need additional FSH in addition. But if we give ACG to increase testosterone levels, we sometimes see that FSH goes down. And in these cases, we also substitute FSH. This is correct. So it has a role maybe only in those men in whom the FSH goes down, maybe below 10 units per liter. Then we would give additional FSH because it's of course also required. But usually it is so high that we do not have to give additional FSH. But it really depends on the case.
Vâng, em cảm ơn.
Vâng, các bạn còn câu hỏi nào nữa không ạ? Tôi nghĩ là về cái chủ đề mà Klinefelter thì chúng ta cũng có lẽ là chúng ta sẽ kết thúc ở đây, bởi vì vấn đề là nó chưa rõ ràng. Tất cả là kinh nghiệm thôi. Thì tôi cũng xin comment thêm mấy cái kinh nghiệm mà tôi từ nãy đến giờ nghe các bạn đặt câu hỏi rất là nhiều về Klinefelter. Chúng ta xác định rằng Klinefelter là bản chất là một cái suy sinh dục tiên phát. Vì vậy mà tất cả các liệu pháp HCG hoặc là thêm FSH vào nó đều không có tác dụng mấy. Tuy nhiên có một số trường hợp nhỏ có tác dụng, đấy là những trường hợp mà có thể khảm nhiều hoặc khảm ít, thì những trường hợp đó thì các bạn có thể sử dụng thêm HCG hoặc FSH. Thì kinh nghiệm trên lâm sàng của tôi trường hợp nào thì chúng tôi dùng HCG hoặc FSH, đấy là những trường hợp mà có Klinefelter, có testosterone thấp, có LH thấp, FSH thấp thì chúng tôi có thể sử dụng thêm cái HCG, hoặc nếu bệnh nhân mà có nhu cầu để sinh con thì dùng phối hợp thêm FSH. Nhưng mà đến 12 ca mà tôi làm trong tay tôi chưa thấy thành công ca nào cả. Đấy là những cái mà chúng tôi dùng. Khi mà dùng những trường hợp đấy thì nồng độ testosterone nó có lên, nhưng mà quá trình sinh tinh thì tôi cũng chả thấy ca nào, microdosing vẫn không. Thế còn trong tất cả những trường hợp mà Klinefelter mà đã testosterone thấp rồi, LH rất cao, FSH rất cao thì chúng ta không có chỉ định sử dụng thêm HCG hoặc là FSH, bởi vì nó không làm tăng thêm cái cơ hội tìm thấy tinh trùng ở những bệnh nhân Klinefelter. Đấy là những kinh nghiệm mà chúng tôi từ phía khoa Nam học và khoa Nam học và y học giới tính bệnh viện Đại học Y Hà Nội thì chúng tôi chia sẻ với các bạn như vậy. Và có lẽ rằng là sẽ có rất là nhiều kinh nghiệm, bởi vì chúng ta biết rằng nó base evidence cái này nó chưa có. Cho nên là tôi rất mong muốn rằng là trong topic lần sau tôi sẽ dành một phần để trở lại với cái đề tài này. Và nếu trong quá trình 1 năm tới các bạn sẽ cố gắng để dành những câu hỏi của mình, chúng ta sẽ trao đổi vào trong đấy. Và bây giờ thì cũng là thời gian cũng là kết thúc, thì chúng ta cũng sẽ phải nói lời cảm ơn thầy Zisman và nói lời chia tay với thầy. Hy vọng rằng trong năm tới thầy đến với chúng ta với lại rất là nhiều những bài giảng hay, rất nhiều những evidence mới. Và thật sự là cảm ơn thầy. Thầy đã luôn đồng hành với các bác sĩ nam khoa của Việt Nam.
Yes, thank you very much for inviting me. So it's always an honor to speak there and to be with you. Oh, thank you. I hope that it was a fruitful discussion for you. It was definitely for me. I really enjoyed it.
Thank you, Professor.
Goodbye.
Goodbye.
Cảm ơn thầy. Hy vọng là thầy out rồi. Ok rồi. Thế thì bây giờ chúng ta sẽ chuyển sang cái phần cuối cùng. Cái bài phần của tôi lúc nãy là đã chuyển xuống cuối. Vâng.